Hi guys, welcome back. The topic we're studying now is motor neuron disease and a subtype of it that is called as amyotrophic lateral sclerosis. Before I explain to you the meaning of the term ALS, I just want to highlight regarding this renowned astrophysicist whose name is Stephen Hawking. He was diagnosed with motor neuron disease way back in 1975. He was told by his doctors that he has only 3 years to live and he will die because of diaphragmatic paralysis slash respiratory failure. But thanks to his dedication and desire to live, he was the longest living survivor of the topic that we are studying today, that is motor neuron disease and a subtype that is amyotrophic lateral sclerosis. In fact, at this juncture, I want to highlight that people with neurological illnesses, once they become incapacitated, once they become bedridden, that is when respiratory failure and pneumonia can strike. In my Parkinsonism discussion, I have talked about the great Muhammad Ali, the biggest heavyweight champion of all times. He suffered from Parkinsonism, became bedridden, and we lost him to pneumonia. Our dear Prime Minister, that was Shri Atal Bihari Vajpayee, who won the Kargil war for us. He suffered from Alzheimer's disease and we lost him to pneumonia at Ames Hospital. And then Stephen Hawking again died because of lung infection. So the message is that respiratory failure and lung infections are the major causes of mortality in patients who are having neurological illnesses that would incapacitate the person. When you focus on the word amyotrophic, it basically means that there's going to be denervation of muscles. And why is going to be a denervation of muscles occurring in this case is because there's going to be damage to the anterior horn cells of the spinal cord. I'll teach you why those anterior horn cells are damaged, but at the moment the message is that the patient will be having features of lower motor neuron lesion, that would be like fasciculations and areflexia. But then when you focus on the next terminology, lateral sclerosis, it means that there is also the involvement of the corticospinal pathway in this condition. This disease is characterized by thinning of the lateral columns, which means that corticospinal pathway is also getting involved. And well, the bad news is if the corticospinal pathway will get involved, then the patient will develop features of upper motor neuron lesion, like for example, spasticity and brisk reflexes, and maybe even a Babinski sign written in the question. You will realize here that I'm teaching you a medical disorder in which there is a combination of lower motor as well as upper motor neuron manifestations developing in a single case. Traditionally, we either study about lower motor or we study about upper motor, but here it's a combination present. Three medical neurological disorders where you get a combination of lower motor and upper motor are subacute combined demyelination of spinal cord, that's going to be seen with B12 deficiency, Friedreich ataxia, which is due to frataxin gene, and the current topic that we're studying, motor neuron disease, and it has three subtypes, out of which amyotrophic lateral sclerosis is the one usually asked, so that is why I've written it right on the top. I want to highlight that if he says which is the most common subtype of motor neuron disease, I'll mention the names of the three subtypes when the time comes. At the moment, I just want you to remember the question. The most common subtype is amyotrophic lateral sclerosis. Guys, this is a neurodegenerative disorder of adult onset. Normally, you will read the word neurodegenerative in pediatrics. You know, when you read Tay-Sachs disease, metachromatic leukodystrophy, Sandoz disease, that is when you're going to read terms like neurodegenerative disorders. But today I'm teaching you a neurodegenerative disorder which is not having a pediatric onset, but surprisingly, adult onset. I will now be talking about the pathogenesis of motor neuron disease. So let's have a look at why does it develop. The disease can have both genetic reasons as well as it can be sporadic in onset also. In fact, there's an important gene that should be remembered from the exam perspective by the name of SOD1 gene. Well, the function of this gene is that it is responsible for controlling the activity of superoxide dismutase. And what does superoxide dismutase do in the body? It controls the free radicals, it neutralizes the free radicals. Now, if this gene is defective, then the activity of superoxide dismutase would definitely be lesser, and the ability of it to neutralize the free radicals will be substantially reduced, and therefore there would be free radicals that can actually damage the anterior horn cells in the spinal cord, the pyramidal neurons in the brain, and even the corticospinal pathway can be damaged in this case, resulting in thinning of the lateral columns per se. So free radical induced damage in this patient is because of genetic reasons. The second gene again has a very interesting name. It's called as C9orf72 gene. Well, the problem in this gene per se is again of interest to the examiner because the problem in the gene would be referred to as hexanucleotide repeats. I wanna repeat the fact, or I wanna highlight the fact that I have taught you disorders that you would have even said or read or noticed the pathologist even speaking about disorders of trinucleotide repeats. I have taught you hexanucleotide repeat disorder, amyotrophic lateral sclerosis / motor neuron disease. Trinucleotide repeat disorders, I think they are very straightforward. The names are Huntington's chorea, that I've written as HD, Huntington's disease. Then would be Fragile X syndrome, where you will have a tall male with mental retardation with I would say large ears and large testes. And then the third one is myotonic dystrophy. So when it comes to the names of trinucleotide repeats, we are still relatively more comfortable. But I have today sensitized you to the term hexanucleotide repeats for amyotrophic lateral sclerosis. The disease may not only have a genetic basis but can be sporadic in onset as well. Now let us see what is going to be happening in the neurons of this particular person from a pathology perspective. I'll speak about 3 points, where the third point will be relatively more important. The first and the foremost thing to be remembered is that there is going to be a defective protein degradation in the neurons of this patient. Well, this happens in most of the neurodegenerative disorders. The second problem would be defective RNA processing. And the third one will be having rather, I would say, therapeutic implications as well, because he talks in the textbook regarding excitatory amino acids causing damage. In this case, he will write the word excitatory damage, or in fact, he might write excitotoxicity. Very interesting term. Excitotoxicity basically means that neurotransmitters like glutamate, you see GABA is inhibitory but glutamate is excitatory. Too much of anything is bad is the basic message here. So glutamate levels as well as aspartate in excess can contribute to damage to the neurons. All the 3 points that I mentioned here are from the pathology perspective, that what's the problem inside the neurons of a person who's having motor neuron disease. It's going to be defective RNA processing, there's going to be a defective protein degradation and excitatory damage. Point number 3 is important because the drugs that were developed to control this were actually having a activity to decrease the value of glutamate. Like you would have studied regarding riluzole in pharmacology for management of this condition. Normally I talk about the treatment part towards the end, but here I would just like to highlight, why do we use riluzole for these patients is because it will neutralize this excitotoxicity. Riluzole, if you read the mechanism of action, has been shown to decrease the values of both glutamate as well as aspartate and thereby cause an improvement. The second drug that is asked in the exam for management of this condition is edaveron. Apart from that, obviously because there's gonna be lower motor neuron manifestation, there can be a foot drop. Because of this foot drop, he might be having a slapping gait, he might have difficulty in walking. So even foot splints would be required for the patient, or foot drop splints would be required. The message is that physiotherapy plays a very important role, and that is where technology comes in. That is where Stephen Hawking was able to live that long, because Americans have technology backup behind them. So they were able to provide definitive support to this guy. Like he had a computerized wheelchair that was battery operated. He could actually read a textbook, he could read a novel in his laptop, he could control the novel, or he could control the laptop with his eyes. You see, problem is you can scroll, but in this guy, there was paralysis of the hand, so he could not have scrolled his laptop with his finger per se, or device with his finger. So he was rather using his eyes to control his device. Lots of technology behind ensuring that he lives. And in fact, I'm showing you a very interesting picture. Stephen Hawking in space. Looks very surprising, no? They took him in a wheelchair. His wheelchair was taken to into space, where they released him from his wheelchair, and you can see him floating in zero gravity. This guy, the number one astrophysicist, was talking about gravity all the time. They wanted him to experience zero gravity. So they took him to space and, just disconnected him from his wheelchair, and you can see him, floating in space. Must have been a great experience for the learned man. And the highlight of this disease is that his brain was working all the time. Right till the time that he died, his brain was working out complex mathematical problems of physics. So higher mental functions are perfect in this condition, but see, his body could not perform. He was wheelchair bound because he was having features of combination of lower motor neuron as well as upper motor neuron lesions. And that is why I was talking about physiotherapy playing an important role, or technology playing an important role for management of these patients. Just for the sake of completion, I want to say that because these patients might develop contractures, so a finger extension splint will definitely happen or help these patients apart from the drugs. Ultimately, because respiratory failure, in fact, that's an important question that I had said verbally but had not written. The number one cause of death in amyotrophic lateral sclerosis slash motor neuron disease is respiratory failure, followed by pneumonia. Both of them can definitely be given in the options. First answer is respiratory failure. So therefore, since we know that he will not be able to ventilate, therefore you might have to intubate these patients. But the problem is you cannot intubate for more than 14 days continuously, because then they could be tracheal stenosis. So tracheostomy would be required in these patients, and moreover, if these patients will develop bulbar palsy, then they may not be able to even drink, they may not be able to talk, they may not be able to express themselves, as was happening with Stephen Hawking. He developed bulbar palsy, unfortunately, and because he could have aspirated on his own secretions, he would have also required chest percussion devices and cough assist device also. The message that I want you to understand from this particular slide is mainly the word excitotoxicity is one of the important pathological reasons behind development of damage in the both peripheral as well as the central nervous system of this patient. And now I would be rather drawing a diagram to actually explain how the manifestations will actually evolve. You see, initially, when Stephen Hawking started suffering from this disease, he started developing weakness in his leg. Now, that was a very non-specific complaint when he went to his physician with this one. You see, this guy was way back in 1975 studying at Massachusetts Institute of Technology. That is when he started having these symptoms, and there's a movie in Star Movies also, or like on Netflix, etc. You can see this movie on Stephen Hawking where he has been shown to develop these manifestations of neurological weakness. And when the doctor is examining him, there was mention of fasciculations developing in the thighs of this guy. When the doctor would have examined his knee jerk, it would have been absent on one leg. Other leg was okay. Like if you see the wedding picture of Stephen Hawking, you can see him standing with his bride, and he was standing with help of a stick. This stick is to basically provide strength to this particular leg, and at that time even polio was common in America. So initially his doctor was thinking that is he having features of poliomyelitis where his one leg is having this weakness. As a result of it, well, he actually had to limit his mobility. His ability to walk towards classes will definitely be hampered. If foot drop will occur in the patient, he might write the word slapping gait. Most of the time, the neurological deficit that develops in motor neuron disease develops over months to years. In Guillain-Barré syndrome, the manifestations can develop very fast over a span of as little as 4 weeks. But here I am talking about neurological manifestations developing over a large number of years. So when they give you a question, he might actually talk about weakness in only one leg. And then the same person after 1 year or maybe 2 years, so I'm just saying hypothetically, maybe 1976, that is how they were showing in the movie. This guy in his opposite hand, I'm showing on the same hand though, he was starting to have development of weakness in his hand also. His hand movements were getting compromised. His ability to use devices was getting compromised. There was cramps. Cramps would mean spasticity. When the doctor examined him, he was having brisk biceps jerk. Now you can very well see the combination of lower motor and upper motor in a single case, along with asymmetrical nature of the disease. It could be left leg and the right arm. It could be the left arm and the right leg. So I mean asymmetrical involvement. It will always be a gradual onset weakness spanning over months and years. So every time you read a question like this, which is having combination features, asymmetric gradual onset weakness, the diagnosis definitely not Guillain-Barré syndrome, definitely not a chronic inflammatory demyelinating polyneuropathy. The good news about this particular disease is that eye movements are still preserved. So right till the end, he could actually read those big books of physics with those complex mathematical formulas. And because he could not use his hand, he used to do calculations in his mind only. I mean, this guy has written research papers on complex mathematical problems which you and me won't be able to even understand. And it is documented that this guy has read the Einstein's complete book of theory of relativity. In fact, I'm saying a surprising fact in this lecture that it is documented that only 7 people in the world have been able to read the entire book of Einstein, the theory of relativity, and understand what he really meant. This guy was one of them. His eye movements were preserved right till the very end. Bladder and bowel movements are also controlled very well in these patients. So, as such, I can say hygiene will still be maintained, because after all, you can see in neurological illnesses, bladder and bowel is also control is gone. Then the person will become unhygienic, and the family members will have a tough time putting on a diaper on the adult man, removing the diaper from the adult man. In this case, I want to highlight that bladder and bowel per se, the movements were definitely preserved. Apart from this, higher mental functions are also normal right till the very end. So this is itself a question, what is going to be normal in this condition? Eye movements are perfectly normal, bladder bubble control is normal, and higher mental functions are normal. But apart from that, I can say though the brain is functioning fine, the body is not following its commands, that there is spasticity in the arms and there is a flaccidity developing in the legs of this guy. In the later part of the disease, he even developed bulbar palsy. Now, what are the features of bulbar palsy? Well, if there is going to be involvement of the ninth nerve and the 10th nerve per se, then the person will not be able to even drink water. There will be high chances of aspiration, especially because vagus is gone. In these patients, if 12th nerve is involved, the person can't even talk. The person can't even eat properly. So if you ever read this phrase, can't drink, can't talk, can't eat, they are basically features of involvement of 9th, 10th and the 12th nerves. And in some cases, they might even be, if the person tries to drink, not only there can be risk of aspiration, but there could be water or milk coming out from the nose of the patient. So in this guy, they had to do a jejunostomy, a feeding jejunostomy, so that they could take care of the nutrition component of him. Now, from the exam perspective, I can say that you can divide the body into 4 parts here. The bulbar part, right? Just neck and above. Then is going to be cervical, supplying the arms. Then can be thoracic, and then is the lumbosacral involvement. So, if he says in the medical literature that out of the 4 segments that I've written here, the 4 segments that I'm talking about is bulbar, then is going to be cervical, then thoracic, then lumbosacral. If it is at least 3 or more than 3 segments that are getting involved, then it is sure shot diagnosis of amyotrophic lateral sclerosis. Let me describe these 3 segments to you. You have a patient today who has been brought to you on a wheelchair. Why on a wheelchair? Because he is developing weakness in his left leg, which is so bad that he can't use the entire left leg. Now, adult person with weakness of the left leg, okay, if it is only one leg getting involved, you could have thought it could be anterior cerebral artery stroke. But when you examined him, you found that there was no spasticity, it was flaccidity. On further examination, you notice that in the opposite side of the body, maybe one arm of the patient, he was having brisk reflexes. The guy was talking to you, or he was trying to talk to you, but at the same time I can say that this person was having at least 2 involvements, right? That is the cervical involvement and the lumbosacral involvement. And gradually, as the disease will progress in this individual, there can be involvement of bulbar palsy developing also. And as the manifestations of the disease will develop sequentially, so in the subsequent visits he can develop bulbar palsy also. So that is where I said if 3 segments are getting involved simultaneously in a patient over a period of time, that basically means that he could be suffering from this neurological disorder, though this is definitely a diagnosis of exclusion. Let us now discuss the workup of this particular case who's having an asymmetrical weakness. Well, I want you to remember overall that if you suspect a person is having a neurological weakness definitely present, you must always rule out electrolyte imbalance, that is hypokalemia. This is always a diagnosis of exclusion. If hypokalemia have been ruled out, then I need to think that okay, it could be a disease related to the nerves. So the test that I can do to evaluate whether the nerve is functioning properly or not can be nerve conduction velocity. If the report of electrolytes and nerve conduction velocity is also normal, I could be thinking that the problem could be in the muscles of the person. The test I can write for evaluating the muscles can be CPKMM values, including a muscle biopsy. And when I looked at the report, I found that the CPKMM values and muscle biopsy was also normal. So if the problem is not of electrolytes, not a disease of nerve, not a disease of muscles, then the problem could be at the neuromuscular junction. Now, traditionally, we are aware of the fact that neuromuscular junction diseases, especially when it comes to myasthenia gravis, will present with drooping of the eyelids and asymmetrical ptosis. But my point is, I still need to rule out whether there is a Lambert-Eaton syndrome or myasthenia gravis present in the patient. So, the antibody test that I can do to rule out the possibility of myasthenia gravis can be anti-acetylcholine receptor antibody. You see, this antibody will actually block the acetylcholine receptor and it will not be able to act. Similarly, another antibody test that you should be aware of and is done in patients of myasthenia gravis is anti-MuSK antibody. I also did anti-P by Q antibody, which is against the calcium channels and is used to rule out even possibility of Lambert-Eaton syndrome. None of the tests are coming out to be conclusive, so I thought that there is a problem with the sodium channels present here. You see, the sodium channels will allow sodium to go inside and potassium to come outside. The channel that I'm talking about here is SCN4A, and there could be channelopathies causing weakness in the individual. Channelopathies could be like hypokalemic periodic paralysis, hyperkalemic periodic paralysis, and I've discussed them separately in the inferior part of the app only. So investigation that I'm doing next in the patient is actually genetic studies. And these genetic linkage studies are what I am doing for evaluating for abnormalities related to this channel per se, which can contribute to weakness manifestations. You see, the tests are turning out to be normal. I have ruled out a neuropathy, I've ruled out a myopathy, a disease of the neuromuscular junction, including a channelopathy. So is it that I'm missing out something? Is this guy having malingering, which is responsible for this weakness in his arm and his leg? Or is he having a genuine medical cause, which I'm missing out at the moment? Well, what I'm missing out in this particular case is like this. If you look at this cut section of the spinal cord, and this be the muscle, you see the muscles would be having muscle spindle, which is responsible for regulating the tone in the muscle. And then we also have what we call as the Golgi tendon. This Golgi tendon is responsible for regulating the tension in the muscle. I repeat the statement, the tone of the muscle is regulated with help of muscle spindle. And when it comes to the tension in the muscle, that would be regulated by the Golgi tendon. So the impulses will flow into the spinal cord and back from the spinal cord in this particular fashion, and we have is the reflex arc. So what I am saying here is damage to these anterior horn cells by the excitatory amino acids and the free radical induced damage. The main site of lesion in these patients, why you have lower motor neuron manifestations, is actually damage to the anterior horn cells. It is not a necessity that only anterior horn cells can be damaged. Even the pyramidal neurons in the brain, that is the neurons in area 4, that is the motor cortex, can also be affected. In fact, there could be thinning of the lateral columns or thinning of the corticospinal pathway that could be involved in this condition, or it could be a combination also occurring in the patient. You see, if anterior horn cells are alone involved, it would be lower motor neuron lesion. If pyramidal neurons or thinning of the lateral column is the presentation of this patient, then he will be having upper motor neuron manifestations, and then can be a combination as well, as I was highlighting earlier. Now the technical names that I want you to remember, and this is again an important part of the slide, is like this. There is a distinct possibility that in a question of motor neuron disease, he may at his discretion give only features of lower motor neuron disease. Then the technical term that you will use to describe this patient who's having only lower motor neuron manifestations is called as progressive muscular atrophy. This is one of the variants of motor neuron disease. There's a possibility that he might describe only features of upper motor neuron disease, so you will call it a progressive lateral sclerosis, where you have thinning of the lateral columns in the spinal cord plus damage to the pyramidal neurons. And if you are gonna be having a combination of the two, that is where this term would come up, that is amyotrophic lateral sclerosis. This would be having both lower and upper motor neuron manifestations together. Out of the 3 varieties that I mentioned here before you, the third one happens to be relatively more common. This table that I made before you is important for this particular topic, because you should be clear about the fact that there is a distinct possibility that patients may not have both a combination, they might be having either of these manifestations. Plus, I have already explained to you that for diagnosis of ALS, you need at least a sequential involvement of at least three segments in the body. Like they could be bulbar palsy developing, so person can't feed, person might be choking on his secretions. There would be cervical, so arm involvement would be there, and then lumbosacral, so the leg involvement will be there in the person. One of the tests that might provide some hint towards the diagnosis of this condition is electromyography. I'm not saying that electromyography is the investigation of choice for this condition. You see, this is a diagnosis of exclusion. You need to rule out electrolytes, nerve problem, muscle problem, neuromuscular junction disease, then channelopathies, then electromyography, which will give you a bit of hint. And if you're not able to make a diagnosis, then there are only two possibilities: either the current topic or this is a psychiatric case. The person is malingering before you. In electromyography, what will be the report written? This report can be written in any etiology of lower motor neuron lesion. The word written will be denervation pattern. So I repeat my facts again. Don't be under impression that electromyography is diagnostic feature for this condition or it's the investigation of choice for this condition. It is just the fact that this investigation per se gives you a hint that there's something wrong with this guy. Why is the denervation pattern coming when there are no nutritional deficiencies? Serum vitamin B12 of this guy is perfectly normal. You see, one of the important causes why person can have peripheral neuritis is vitamin B12 deficiency. He's not on drugs as well. The values of serum vitamin B12 or Schilling's text are perfectly normal in this chart. When it comes to Guillain-Barré syndrome, guys, I have highlighted that the manifestations will be a pure lower motor neuron lesion and the manifestations will develop over less than 4 weeks. In chronic inflammatory demyelinating polyneuropathy, again I've highlighted features will be of lower motor neuron lesion, but the manifestations would be spanning over at least 9 weeks. In this case, I have said years. So the message is loud and clear. If it's a neurological illness which causes weakness in the arm and the legs of a patient in an asymmetrical fashion spanning over large number of years and especially over three segments, that is bulbar, cervical, thoracic and lumbosacral areas, then you have to suspect this particular disease. So this will always be kept at the bottom of, I would say, the discussion pool. Bulbar palsy can anyway be asked to you itself as a topic, so I would just like to invest few seconds into explaining this to you as well. You see, you will read terms like bulbar and pseudobulbar palsy very frequently in neurology. The meaning of the word bulbar palsy per se would be the damage to either the nucleus or to the nerve per se, like if there's damage to 9th, 10th, 11th, 12th nerve. 12th nerve involvement will definitely affect the tongue, and if the tongue is involved, then swallowing will become a problem for the patient. Difficulty in talking will also occur in the patient. You see, if the damage is in the nucleus of the nerve as well as the nerve per se, we call it bulbar palsy. And then we have innervation in each of these nuclei. You see, the innervation is coming from the cortex. This is what I'm saying. The red fibers that are drawn before you are called as corticobulbar fibers. These corticobulbar fibers, if are involved, then we call it pseudobulbar palsy. Well, how can you differentiate between the two? You can easily differentiate on the basis of examination of the gag reflex, because bulbar palsy is gonna be pure lower motor neuron manifestation. So if the damage will occur to the 9th and the 10th nerves, you will notice that the gag reflex of the patient will be absent and the tongue of the patient will be flaccid. It will rather exhibit a deviation. If you ask the patient to take his tongue out of his mouth, the tongue will deviate to the same side. Ipsilateral tongue deviation will be noticed. But when it comes to pseudobulbar palsy, the person will have a spastic tongue. He will have difficulty in taking the tongue out of the mouth because it is spastic, and at the same time the gag reflex of the patient will turn out to be brisk. But in this particular disease, I especially want you to remember the term bulbar palsy can contribute to even these patients choking and dying, because if the relative will try to feed them, then everything can go in the lungs of these patients. This is obviously a diagnosis of exclusion. I would like to finish this topic by lastly mentioning once again medical disorders where combination of lower motor and upper motor neuron manifestations are given are subacute combined demyelination of spinal cord, which is due to vitamin B12 deficiency. Then is Friedreich ataxia, which is due to frataxin gene. And lastly, the current topic, that was motor neuron disease, where there was a subtype that was discussed, amyotrophic lateral sclerosis. In fact, couple of years ago on Facebook, etc., there was a ice bucket challenge also. You would have seen Bollywood and Hollywood celebrities celebrating this ice bucket challenge. Alia Bhatt from Bollywood was also doing this ice bucket challenge. She's putting ice bucket on her head. That was to increase the awareness of this medical disorder. The main objective of this discussion is to sensitize you to the gradual onset weakness that I've highlighted multiple times. If developing asymmetrically over large number of years at more than 3 segments, the diagnosis of this condition can be worked out. And this obviously has to be in this right perspective. I mean, if you get this algorithm right, the way I've ruled out the various medical disorders ranging from neuropathy, myopathy onwards, then you definitely will be able to evaluate and get this question correct. Thank you so much for hearing me out.